Mr. Raja, you can start.
All right, sir. So, good evening, doctors, senior faculties, and the students. We are extremely happy to welcome you on this auspicious day. Wish you all very happy Yugadi. It's been a special festival. This particularly been celebrated in southern part of the country. Of course, in various other names in Maharashtra and other parts of the country. It's a good start in the new year. That's what we consider. So, but coincidentally, this happens to be our last program of this particular edition. So we are extremely happy to welcome one and all of you for today's event, particularly our course directors, Dr. Lieutenant General P.P. Varma ji, Dr. Vijay Kher, and Dr. Vinay Sakhuja. So before we move on to the program, I request Dr. Varma ji to introduce the examiners of the day as well as the discussant and the topic and take the program forward. Over to you, Varma ji.
Thank you, Mr. Raja. It's a pleasure to be here, and this is the 24th master class. We had planned 24 clinics, and today happens to be the last clinic for this master bedside. And I'm glad to say that students have liked the program. At least wherever we have gone, they have liked the program, and this is purely because of excellent examiners we had throughout. Always the examiners had put in very hard work, and they gave the best what they can give to the students. Because of that, the program was successful. Today again, we have got two very eminent and academically strong examiners. We have got Professor Shyam Bansal, who is Director and HOD Nephrology in Medanta, Medicity Hospital, Gurgaon, and Professor Raja Chandran, who is the Associate Professor of Nephrology at PGIMER, Chandigarh. Both of them are very respected faculty, respected teachers, and they are astute clinicians. Dr. Bansal and Dr. Raja are acknowledged as national scholars in the field of nephrology. I'm glad and I welcome both of them for this master class. There are two students today, Dr. Simran Sawhney. She is a DNB student from Medanta Medicity Hospital. She is Dr. Shyam Bansal student. And the other is Dr. Arun Prabhahar. He is a student of Dr. Raja. He is from PGI Chandigarh. May I request the first student, Dr. Raja, this is Dr. Arun Prabhahar, to start the presentation, and I'll request Dr. Shyam Bansal to please conduct the session. Over to Dr. Bansal.
Yeah, thank you, Dr. Varma, for nice introduction. And I missed the last session because of some personal reason, and I think coming for the first time, so I am not aware of the proceeding, but I think let's start with the case, and then it will be taken further. Dr. Varma,
Yeah, that's right.
So, can I start sharing, sir?
Yeah, sure. Somebody need to put Dr. Raja is also joined in his panel. He's asking.
Yeah. I've just joined. I've been
welcome, Dr. Raja. Welcome.
I was in the audience. I was listening to everybody speak.
Welcome, sir. Welcome, Dr. Shyam. Welcome.
You know, the topic for today is kidney involvement in malignancy. So we don't know. Both the teams are presenting their cases. Let's see what we have.
Good evening, everyone. Good evening, respected faculty members, and good evening, my friends. So today is I'll present a short history and investigations of an interesting case which we recently saw today, and I'll present the clinical and investigations part one by one. So she is a 65-year-old female hailing from Chandigarh. She is a retired officer, and she did not have any comorbidities. And she presented to the general physician in somewhere in an outside hospital with a history of dry cough for 3 months. And there was associated significant loss of appetite and loss of weight. There was no history of fever. And she was feeling weak and after she came back from a foreign trip. Otherwise, there was no associated symptoms, and she did not have any history of phroturia or hematuria or decrease in urine output or edema with respect to the kidney part. These were her initial complaints. So with this, she visited the private practitioner there. So private practitioner investigated her with the chest X-ray, and the routine investigations were normal. And in the chest X-ray, they noted that there was bilateral hilar prominence and increased bronchovascular markings as shown in the chest X-ray here. So I have just the lung window cuts. So the initial CT scan revealed multiple peribronchial and perivascular discrete clustered pulmonary nodules. So in this initial CT, we just see some of the nodules which I have marked in the with the arrows. So there were nodules which probably the initial radiological impression was whether they probably deemed it as metastatic nodules, then an infective pathology. And there were also multiple heterogeneous enhancing necrotic mediastinal lymph nodes and bilateral hilar lymph nodes. So combining both these two things, they suspected a possibility of a malignancy, and the primary was investigated. So this was the CT abdomen of the same patient, which was done later to find the etiology of the primary malignancy, and it showed a mass from the superior pole of left kidney as marked in the arrow. There was also a hypodense enhancing filling defect in the left renal vein. So a diagnosis of renal cell carcinoma with metastasis and with a renal vein thrombosis, likely a tumor extension, was made. So the patient was subsequently worked up in oncology and urology departments in our hospital, PGI Chandigarh. So a PET scan was later done. In the PET scan, even though I am extremely sorry for the poor quality image, but in the PET scan we can see the superior pole of the left kidney showing a FTG avid mass and multiple lymph nodes in the mediastinum. In the second image, we can see the mediastinal nodes enhancing, and in the third image, we can see the nodules which have increased in number and size compared to the previous CT which I had shown. So with this, it was the diagnosis of renal cell carcinoma was reconfirmed, and the patient subsequently underwent so this is the exact PET report. There was a heterogeneously enhancing large lobulated soft tissue mass from the left upper pole, the left kidney's upper pole. And there was lymph node involvement on both the sides of the diaphragm, upper and lower, and in bilateral region. So there was extensive lymphnodal involvement. So a biopsy was done, which showed.
Arun, we can stop here and maybe you can ask, it's not a general practice to do kidney biopsy in a renal mass. It's an MBBS teaching that you don't do a kidney biopsy in a renal mass, because when your provisional diagnosis is renal cell carcinoma, which it fits the bill. So a biopsy was being done. So what was the reason for this, do you think?
So because she was not a case where a resection can be made, and also considering the tumor invasion into the vein, probably that's why the surgeons thought that biopsy could have been a better choice before proceeding with the palliative therapy, considering the extensive metastasis she has. Then they would have thought that the resection is not an option.
Yes. So here the patient, it was a non-resectable tumor because it had already spread to the lungs, probably. So that is the reason they thought that they should have a confirmatory diagnosis before they plan chemotherapy and to know the nature of the tumor. Yeah, please proceed.
So I'll go slowly with the investigations one by one, sir.
Yeah.
I got this information from the oncology colleagues. They scored they made the risk stratification of this patient through IMDC scoring, that is International Metastatic Renal Cell Carcinoma scoring, in which they had taken into account time from diagnosis to systemic therapy, because she was planned for not a routine therapy. She was planned for an immunotherapy. That's why they took this classification into account. So the performance status, hemoglobin, calcium, and neutrophils and platelets, all these things were taken into account, and she was classified as intermediate risk, with which the median survival expected was 22 months. The renal functions at the time of diagnosis was normal, 0.8 milligram per deciliter. Urine routine microscopy was normal, and the TSH value is 2.71 micro international units per ml. So I'll proceed with the next, sir.
Yeah. So please proceed with the clinical course.
So with this intermediate risk and considering the lifetime survival for this patient, though she was without any comorbidities and functional status was good, so she was given dual therapy. So dual therapy in the sense she was given pembrolizumab, which is an immune checkpoint inhibitor, and axitinib. Axitinib is actually a tyrosine kinase inhibitor. I have marked it with the stars. Axitinib is a VEGF inhibitor, tyrosine kinase inhibitor. So she was given these drugs. I'll mention the course. Can I go forward, sir?
Yeah.
She was given through intravenous route every 3 weekly, and along with that she was given axitinib, which is an oral drug, at the dose of 5 milligrams twice daily, and she received the first dose of pembrolizumab on 23rd December. After the first dose, she developed, after 3 or 4 days, she developed oral ulcers, maculopapular rash, and macrohematuria. Subsequently, over 1 week, the symptoms resolved. So she consulted the oncology team. So there's some noise. So
can somebody check at the back end? I think it's calm now.
Yes. The renal functions were normal, and even though the hematuria part had resolved, so she was given this next dose of pembrolizumab after 3 weeks duration, which is the usual course there. And she also developed a recurrence of the same symptoms, and this time the symptoms were followed by frothuria. So she was not a hypertensive before, but she started, there was new onset hypertension which required 2 drugs, and she also started to notice constitutional symptoms in the form of weakness, arthralgia, mild edema. She also noticed in her feet, but the urine output was normal.
Okay. Can you go to the next slide?
Yes, sir. Can I go? Yes, I'll move. So she was, again, as she developed frothuria, she did not present initially. She came when she started noticing frothing of urine. So by that time, when she came to the OPD, first to the oncology OPD, her creatinine was 3.7 milligram per deciliter. And urine routine microscopy showed 1+ albumin in the dipstick and pus cells in routine microscopy. The 24-hour urine protein did not show significant proteinuria. It was 339 milligrams. And the hemoglobin was, it was around the baseline 8.9, and the platelet counts were more than 4 lakhs. the peripheral smear was done, which did not show any cystocytes. So considering the temporal course, both these drugs were withheld, and she was referred to our nephrology department. So the creatinine when the patient came to us was 4.74. It was increasing. So considering the possibility of interstitial nephritis, which with the temporal course of drug intake, so immunosuppressive therapy was started. And kidney biopsy was not done, as we discussed the case with, there were multiple reasons, which I'll tell later, why biopsy was not done. And also when the supportive findings were that the TSH level had gone up and ANA report was 2+. So we thought that the drug probably is causing an immune reaction to which the kidney is reacting with the likely pathology being acute interstitial nephritis. So steroids we started and continued the drugs.
Yeah. So Arun,
Yes,
so this is the only possibility you would like to keep. I mean, this is a patient who is on 2 of this chemotherapy drugs, and what type of the kidney disorder these drugs can produce? What are the various kidney?
Patients with malignancy. So first start with the malignancy and the kidney part, and I'll go for the drugs part. So patients with the malignancy and kidney part can present with tubular, they can present with tubular, glomerular, interstitial, vascular, and post kidney, post obstructive changes, to be frank. And in her case, we as the patients with malignancy can have per se glomerular pathologies, but this patient glomerular pathologies like minimal change disease, membranous glomerular nephritis, MPGN, IgA nephropathy, amyloidosis, which are the most common glomerular, and MGN, which is very common. And these are all the glomerular pathologies which we should be considering in patients presenting with nephrotic range proteinurias. Other than that, because this patient presented with tubular manifestations and the calcium phosphate profile, which I had not mentioned, was normal, so a tumor lysis was not kept in this patient. And then the other possibility, considering the temporal correlation of such an drug, we kept a possibility of acute tubulointerstitial nephritis, because there was no significant proteinuria, and hematuria, though is common with glomerular cause, can occur even with tubulointerstitial diseases. And also the extra renal manifestations in this case, and mild eosinophilia also we noted. The extra renal manifestations were typically some cytokine related, like rashes, arthralgia. And also we ruled out thrombotic microangiopathy through the peripheral smear and other things, because the drug which axitinib is an VEGF inhibitor. So that is known to cause podocyte and endothelial injury. So that was also ruled out. And finally, obstruction was obviously not there after the ultrasound report, and other electrolyte abnormalities were not there. So finally, we arrived at a diagnosis clinically without a biopsy to acute tubulointerstitial nephritis, and probably we attributed the same to the drug which she took.
Yeah.
Any possibility of some time, because this immune checkpoint inhibitors, they cause the lipusnephritis nephritis. So any possibility because ANA is 2+?
Yes, sir. They are known to cause.
Any possibility of the vasculitis, because vasculitis can also cause some hematuria, but without much proteinuria, and this patient had renal dysfunction, which was significant. How would you rule that out without a kidney biopsy?
Sir, Without a kidney biopsy, these are all usually microvascular changes rather than large vessel vasculitis. So at tissue diagnosis, I would think that would be required, but because these antibodies like MPO and PR3 can be elevated sometimes, so we can check with that. And vasculitis, I answered, sir.
No, this is one of the adverse effect which is seen with checkpoint inhibitor.
Yes,
That can be vasculitis, C3G, and ANA, SLE like nephritis. These
yes,
are also some of the adverse effect of these drugs.
sir.
How do you rule out those without doing a kidney biopsy? Unless you are very sure, no, there is no need to keep any differential diagnosis because we have ruled out some other causes, and that's fine.
No, sir. The other things should be ruled out. It is not the one and only diagnosis. Compliments we did, sir. I forgot to mention compliments were normal. And glomerular cause of hematuria can be one other thing, like if we see through phase contrast microscopy that how we can differentiate between glomerular cause and tubular cause sometimes. And vasculitis, without large vessel, we are not suspecting, but
We are not talking of large vessel. No, this is a renal dysfunction which is predominant. So obviously, mostly it would be small vessel vasculitis, which
sometimes imaging of the kidney with the CT angio can sometimes pick up wedge-shaped infarcts that can give us a clue to rule out the diagnosis of vasculitis. And sometimes skin biopsies can be done, which can tell us the small vessel involvement in the, if they are in the skin vessel and subcutaneous tissue, that can be there, sir.
So, but in this patient, would you do the contrast CT in this patient at this time?
No, sir. Ideally, should not be done, sir. But
how would you make a diagnosis? I am asking you, how would you make a diagnosis of this patient without a kidney biopsy? Or you will just wait to see the response. If the patient is getting better, that is fine. That may be one approach. I don't say it can't be an approach.
Sir, I think without a kidney biopsy, we can look for extra renal manifestations is one thing, like retinal examination, fundus examination, and
Is there examination, fundal examination, retinal examination? So have you done those?
Sir, that was not done in this patient. Fundal examination was not done, sir. But
what do you expect to find in that?
Retinal hemorrhages can be there, sir. And
this patient also, retinal hemorrhage, would that point out to a specific diagnosis? No, retinal hemorrhage.
Hemorrhages can be there with the hypertension, so that will not point to a specific diagnosis, but infarcts and nerve fiber damages.
I think I'll get inside because we are trying to get a little complicated. So if you see this case, it's a simple case. The patient presented with edema and some sort of kidney involvement. So obviously, whenever somebody presents with edema and kidney involvement, your first differential diagnosis is a glomerular cause. So you could have a glomerular cause or a tubular interstitial cause. Glomerular precedes tubular interstitial as cause because this patient presented with edema. So here, but this patient does not have any proteinuria. It's only 339 milligrams. So essentially, we have ruled out glomerular cause as the pathology. Coming next, whether it is acute tubular necrosis or whether it is acute tubular interstitial nephritis, these are the other two differential diagnoses, because there can be other differential diagnoses like lupus, as was discussed, and other things, but usually they have proteinuria, if at all. And whenever these drugs cause lupus like nephritis, you would also have additional manifestations of lupus like arthralgia and others. So this patient does not have proteinuria of more than 500 milligrams. So essentially means the glomerular compartment is largely silent. So coming to the tubular interstitial part, the patient has got some puzzles in urine examination. So I'm not very sure about, how well this urine examination has been performed. So, it could be either acute tubular necrosis or acute tubular interstitial nephritis. So these are the two differential diagnoses. Usually, patients with acute tubular necrosis have oliguria. Classically, if you go with the classical presentation, they have oliguria. Whereas this patient did not have any history of oliguria or decrease in output. So essentially, we could narrow down to tubulointerstitial nephritis as one of the differential diagnoses. So that's how I would, approach this case. But yes, all said and done, you could only, confirm the diagnosis after doing a kidney biopsy. Why we didn't do a kidney biopsy? I think that is because of the logistics, and the patient's attender were uninterested in, going with another intervention at this point of
See, I'm not asking. So there could be many. So I'm not saying. See, why didn't you do? We are just discussing the differential diagnosis. My purpose of discussing was that we should keep all the possibilities open as a differential diagnosis. So obviously, acute interstitial nephritis is the most common cause of renal dysfunction in patient like this, and this patient also had hematuria. So you would not like to keep probably ATN. See, ATN, if the differential hematuria is would be unlikely in patient who have ATN. So it would be either some glomerular disease or it would be tubular interstitial disease.
Other differential diagnosis we should consider is this patient had a thrombus, renal vein thrombosis. That could be one of the cause of hematuria. Yeah. That could be one of the cause. But it would not be the cause of renal failure because, you have two kidneys. Unlikely that, there is a renal vein thrombosis in both the kidneys, which obviously did not show up on the Doppler. So most likely, that's another differential diagnosis for hematuria that we need to factor. Plus the disease per se, the RCC itself can cause hematuria-like presentation. So that's another.
One of the things which he pointed out, which I wanted to highlight, that this ANA, he says, was 2+, which probably became positive after this, unless she had this ANA positivity before. And SLE-like syndrome. And SLE can also have tubulointerstitial sort of presentation. It's not necessary that there is a glomerular disease always in SLE. So that could, so I would just that we should keep more differential diagnosis when you are reaching to a cause of any disease, rather than just keeping one thing in mind. Obviously, this is the most obvious, most common cause. And one thing, did you start the steroid? So sometimes these are because of the mostly it is because of the drug related chemotherapy, and you withdraw the agent. And so did you start steroid immediately after the stopping, or you waited for some time before you started steroid?
Sir, we waited for 3 to 4 days before starting the steroid, and because the renal dysfunction was going advanced to reaching 5 milligram per deciliter, then we discussed with the oncology team, and considering the extra renal manifestations and the likely possibility we can expect from the biopsy, then after reviewing the literature, then we proceeded with the steroid, but we waited for 4 days at least before starting steroids.
So you have also written this TSH is 7.7. So what is the significance of that in particularly related to this case?
Sir, that we actually did all the electrolytes and thyroid function tests, including anti-TPO antibodies. We did to find if there are additional endocrine abnormalities which are very common with immune checkpoint inhibitors. So that was the reason why we did TSH, and we noted that the TSH, which was initially 2.76, rose up to 7.76.
Yeah, thyroiditis is something that can be seen with thyroiditis, adrenalitis. These are things that can be seen with checkpoint inhibitors. Yeah, you're right.
Hypophysitis also.
Yeah, but then I would like to know the complete thyroid function test. If you are suspecting thyroiditis, then there should be T3 and T4 that should also be done, and that should be correlated.
Yes, free T3, T4 was done in this patient, which were normal, and anti-TPO was also done, sir, which was also normal. So just the TSH was elevated in this patient.
Okay, so you can continue further. Yes.
So this patient, after starting prednisolone at 0.5 milligram per kilogram, by first week again the creatinine started coming down 3.7, and when she came 10 days back to our OPD, the creatinine was 1.2 milligram per deciliter. We have started tapering the steroids, and currently she's on 5 milligram OD steroids. And the oncology team did not re-challenge her with the immune checkpoint inhibitors rather than continuing with just the tyrosine kinase inhibitor for this patient. And she did not have any further episodes since starting this drug, which has been 15 days since stopping, 15 days from today. So she did not have any, the hypertension has got normalized, and there is no edema or hematuria or rash, and she also tolerated the HbA1c was 6.6, but the initial before starting steroids, but she did not have any steroid related side effects. The sugars were controlled also.
So what do you think? Do you think you are convinced with your diagnosis of ATIN, tubular interstitial nephritis, or you think there could be any other possibility in this case?
Sir, most likely diagnosis still I consider is tubular interstitial nephritis, considering the clinical picture and investigations he presented with, and the response we got with the immunosuppressive therapy in this patient.
So it is, see, I would not completely agree with this. So this can be a possibility, but you started, see, the effect of the chemotherapy drugs will remain for some period of time. 2 or 3 days, it is not going to go away. So probably, I don't know, you could have maybe waited for 1 week more, and this patient had ATN, this patient probably, and then she recovered rapidly. Within a period of 2-3 weeks, means she came initial follow-up after 1 week, and then follow-up was after 1 month, and she rapidly recovered, and hypertension and everything also disappeared. So that was probably the effect of the chemotherapy drug, and which once the drug complete effect was gone, the patient started recovering herself rather than steroids.
Sir, but if we take this patient before starting the drug, the creatinine was 0.8, and the drug was, yes, sir, please.
I'm not saying, no, so I'm saying this was the effect of the drug, and this diagnosis might also be acute ATN rather than ATIN. The way the patient recovered rapidly after that. But obviously, ATIN remains a possibility. So, but this is a very rapid recovery. Hypertension, everything settled down once you stop the drug.
So I agree. See, you cannot get to pinpoint to a diagnosis without doing a kidney biopsy. Kidney biopsy is a gold standard to establish whether it is a tubular interstitial nephritis or it is acute tubular necrosis. The only thing is, the patients with ATN with creatinine usually progressing so rapidly usually have a decline in urine output. Usually, again, it's not that every time it should happen that way. And classically, even patients who developed acute tubular interstitial nephritis, there was always a debate going whether you should treat them with steroids or just withdraw the drug. Because even withdrawing the drug, the patients, even tubular interstitial nephritis would respond to. But yes, now we know that if you delay the treatment of tubular interstitial nephritis with steroids, they could end up with chronicities. So it will be difficult to really tell whether, why this is acute tubular necrosis or acute tubular interstitial nephritis, because the response to steroids also would be the same. Usually patients with tubular interstitial nephritis respond very well to glucocorticoids. So I would keep it there, it could be either of them, but yes, these were not decisions which were taken primarily by us. So just to, sensitize the students to the case, primarily managed by the oncology and the urology team of the institute.
One more last question. This because ANA was positive. So did you do the complement in dsDNA and follow the ANA later on?
Yes, sir. Complements were done. dsDNA was also done. Both were negatives. Complements were normal and dsDNA was negatives.
And ANA now, after the recovery of kidney function?
So no, sir, we did not do ANA. No, sir, we have to, maybe we'll check it again, sir.
Okay.
Yeah.
So,
Arun, how common is AKI in a setting of malignancy? When you are managing a case of any malignancy, how common generally you find AKI?
So renal function to the tune. Some renal functions in some of the other forms can be seen in up to 30 to 40%, primarily very commonly with hematological malignancies. And this immune checkpoint inhibitor toxicities are reported from 2 to 5% on average to 20% in some series. So if we take acute kidney injury alone, maybe some during the course of the entire therapy, I think we can see in up to 30 to 30%, what I guess.
Professor Sakhuja, your comment, sir. Is Professor Sakhuja
muted, I guess.
Just a minute. Yes. Can you hear me now?
As the discussion went, that patient had AKI, the only debate was whether it is ATN or AIN. Possibly the response the patient had with steroids gave the presentation with hematuria, hypertension, possibly gave a little hint towards AIN, and the response also. Your opinion, sir?
Yeah, I would tend to agree with that, because to have gross hematuria with ATN is very unusual. That would be very unusual. So I am also in favor of acute tubulointerstitial nephritis as the underlying pathology. But as Dr. Raja said, without a biopsy, one can't be absolutely certain. There can always be some room for doubt in this situation.
Yeah. And possibly the recovery, how it has occurred promptly.
Yes.
It might be giving a hint, though logically one can always debate that it is a toxicity due to the drug. That I don't know whether the toxicity due to this particular drug, I am not aware, is pretty fast once you stop the drug.
yeah. So these are common with the checkpoint inhibitors, these toxicity ATN and ATN. No, one of the reasons for the hematuria, especially the gross hematuria, is also not very common in ATIN. It can be there. It could be because of renal cell carcinoma in this patient. No, that Raja discussed that. That could be the reason for the hematuria rather than ATIN. Because he also difficult because that there was an invasion in renal vein and there's a possibility of hematuria, gross hematuria, isn't it?
Dr. Raja, any comment? Otherwise, we close this case. This is a very interesting case and a common case that renal cell carcinoma with infiltration in renal vein, patient going into acute kidney injury, which is pretty common. As Arun said, possibly 1/3 of the patient during the course of management are going to have AKI because of maybe toxicity due to drug or whatever the reason may be, sepsis or whatever reason. So fortunately, the patient has recovered out of AKI. That's important. And the debate always, that's a moot point. What is the underlying etiology is debatable. Any final comment, because you are dealing with the case, Dr. Raj?
No, I agree, sir. Like, I agree on all the points that is made. See, with it's important. Without a kidney biopsy, I think it would, as sir pointed out, we cannot certainly say whether it is a tubulointerstitial nephritis or tubular necrosis. We should encourage, the patients to undergo a biopsy. Obviously, if the nephrologists are the primary physicians, we would be more convincing. But when it is being dealt by the oncologist and urologist, they are the one who are the primary drivers. And if you go by there is a guideline where they say that if somebody has got stage 3 acute kidney injury with immune checkpoint inhibitors, and the diagnosis is looking like tubulointerstitial nephritis, you could as well start on glucocorticoids, and so that is what they follow, and that's why this patient was treated with corticosteroids. So that's the reason. So yes, I think the take-home message is these drugs can cause acute kidney injury, and only a biopsy would tell what it is. Commonly, they cause acute tubulointerstitial nephritis, whereas other differential diagnoses can also be there.
Just one point I'd like to add. Dr. Raja had mentioned a little while earlier that the standard teaching till now has been that in a renal cell carcinoma, you don't do a FNAC or a biopsy.
Yeah.
The diagnosis is largely radiological, and then you go ahead with surgery. That has been the standard practice for a very long time.
Yes, sir.
However, now the thinking has changed on this, and it is felt that like other organ tumors, other pathologies, you can do a biopsy in these patients. Now the belief is that if you want to do a biopsy, you can. Earlier, it was thought that if you do a FNAC or a biopsy, you're going to spread the tumor.
Spread the tumor.
Yeah, disseminate the tumor. So now that is no longer considered valid. So you can consider doing a biopsy or a FNAC if in doubt.
Yes, sir. I actually specifically, it was presented in our Uronephro also, sir. So I asked the urologist sitting next to me, like, now these days, do you do a biopsy or do you proceed? What they said was, if there is no spread anywhere other than the kidney, we don't biopsy, we just go for nephrectomy, we go for surgical approach. We remove the mass. But yes, if there is presence of mets or any atypical features, we do biopsy now. Okay, that's what they do.
And one other point, just small point, that if on a CT scan, you are not absolutely sure about the diagnosis of malignancy of renal cell carcinoma, a contrast-enhanced ultrasound is another investigation which can be used to confirm the diagnosis of a renal cell carcinoma.
Yes, sir.
Point taken, sir. We stop here for the first case.
Yes.
Thank you, Arun, and for a nice presentation and bringing the debate in. May I request Dr. Simran, Dr. Bansal student, to please start the case.
Yes.
Thank you, sir.
Good evening, faculty members and my colleagues. I'm going to start the case presentation. So my case is Mr. V. He is a 72-year-old gentleman, resident of Prayagraj, Uttar Pradesh, and graduate. He is a retired account officer, and he's a non-diabetic. He is a known case of hypothyroid for the past 4 years and has undergone coronary artery bypass graft in 1993. He presented to the oncology department with chief complaints of nausea and vomiting for the past 15 days, generalized weakness for the past 15 days, and decreased urine output for the past 1 week. I would like to start my history from December 2021, when patient had active bleeding per rectum. He used to pass a fresh red colored blood from the rectum, and at that point he showed to a local doctor, found to have an anorectal growth, but he, instead of going to an allopathic doctor, he went to an homeopathic doctor and took homeopathic medicines for a period of 3 months. In spite of taking these medicines, there was no improvement, and then he went to an allopathic doctor where he underwent a surgery in April 2022, and he was told to have a cancerous growth, and at that point he also underwent a contrast study. Following these two things, he was then referred to our center in May 2022. Now here his histopathological examination of his anorectal growth showed nodular melanoma, and a PET scan was done, which was non-contrast, and it showed the exophytic lesion in the rectum, along with some FDG uptake even in the fundus of the stomach, and following which endoscopy and biopsy was done, which also showed melanoma. So he was then diagnosed as a case of metastatic melanoma. So on routine evaluation at that point, he was found found to have a raised serum creatinine, and he was told that it was 2 milligram per deciliter. However, at that point of time, the patient had no decrease in urine output or passage of blood in the urine or passage of urine which was a soap bubble in appearance. He had no shortness of breath or swelling anywhere in the body, and he had no rise in blood pressure. However, on direct questioning, the patient gave history of taking NSAIDs on and off for the past 4 months due to pain in his rectal area. Now in oncology department, he was given chemotherapy. He was given pembrolizumab once every 21 days and till June to September. And then repeat PET CT was done, which showed that the disease was progressing, and hence his immunotherapy was changed, and now he was started on imatinib from October 2022 till date. So during this year, he was constantly being evaluated, and he had a baseline creatinine of 1.5 to 2 milligram per deciliter. However, he was not having any urinary complaints or shortness of breath or swelling or any rise in blood pressure. So then coming to our present illness, so he was apparently all right till March 2023 symptomatically. However, for the past 15 days, he started developing nausea and vomiting, which was non-projectile, and there were about 2 to 3 episodes per day, and the vomitus used to contain food particles, and it was not blood tinged. This was associated with loss of appetite in the form of decrease in the amount of food he used to take per meal, and also associated with passage of dark colored stools, but these stools were non-sticky and non-tarry, and they were not loose. There was no complaints of any abdominal or flank pain. There was no yellowish discoloration of eyes or any complaints of headache or any rise of blood pressure. This nausea and vomiting was associated with generalized weakness, which was insidious in onset, progressive in nature, that so much so that the patient initially could climb one flight of stairs easily, which he was unable to do now, and also associated with shortness of breath on exertion. However, there was no chest pain. There was no difficulty in breathing while lying down or any difficulty in while sleeping. There was no sudden shortness of breath. So and then after 7 days, patient also noticed that there was a slight decrease in urine output. However, he could not quantify the urine, but the amount of urine passed each time was less, as told by the patient himself. However, there was no passage of blood in the urine or any soap bubble appearance. There was no difficulty in initiating urine, no burning while passing urine, and there were no flank pains or abdominal pains. There was no swelling anywhere over the body. There was no complaints of fever. So he was evaluated at that time and found to have a low hemoglobin. He was told that it was 5 gram per deciliter. And then after giving blood transfusion, he was told after 2 days that his creatinine was 2.2, and which increased to 3.5 milligram per deciliter in the next 5 days. He underwent a urine examination and was told that there was passage of protein in the urine also. So this was the chief complaints. When I asked the past history, he is a hypothyroid, non-diabetic, non-hypertensive. He underwent coronary artery bypass grafting in 1993 and a resection of the anorectal growth in April 2022. Among the drug history, significant drug history, he was taking NSAIDs on and off for the past 1.5 years. He took hemopathic medicines in 2021 for a period of 3 months, and he also took chemotherapy here at our center for, and he's still taking. So till date, he's on chemotherapeutic drugs. Among the personal history, he's occasional smoker, drinker, mixed diet, and currently he is passing dark colored stool, and the urine output has now decreased since 1 week. He has a significant family history. His father and his sister both had esophageal carcinoma, and they received radiotherapy, but they died within a short span of being diagnosed. But there is no renal dysfunction in the family. My history, sir.
Can you show the summary again, please?
Yes, sir. My case is a 72-year-old male, known case of hypothyroidism post CABG, diagnosed to have anorectal and gastric melanoma, presented with complaints of nausea, vomiting, generalized weakness for the past 15 days, and decreased urine output for the past 1 day, for the past 1 week, with the past history of contrast study, use of NSAIDs and homeopathic medicines, and he is treated with chemotherapy, checkpoint inhibitor and imatinib, and with a family history of esophageal carcinoma in father and sister.
Show the current reports. No, this is, I think you have described the history and this, but you have not shown the current code. No, just complaint. This is all past history and all that. So you can show what happened to in this admission. What about renal function and other parameters?
Yes, sir. So when he was having these symptoms, first he was evaluated outside when he was found to have low anemia, hemoglobin of 5.1, received blood transfusion, and then got renal functions done. So he was maintaining a baseline creat of 1.5 to 2 in the year 2022. After having this episode of nausea, vomiting, his creatinine increased from 2.2 to 3.5 within a span of 5 days, and when he presented to us, he had a creatinine of 5.4. So from 5th of March to 18th of March, his creatinine increased from 2.2 to 3.5 to 5.4, and so that was the renal function.
So what is your further this diagnosis, differential diagnosis?
Examination, can you tell us?
Yes.
Yes, sir. As examination, general examination, he was conscious, oriented to time, place, and person. He was having a weight of 58 kgs and height of 156 centimeter. He had blood pressure was 110/70, right arm supine position. Respiratory rate was 16 per minute, abdominothoracic, and heart rate was 80 per minute, normal in volume. And he was maintaining a saturation of 99% in room air. He was afebrile, he had pallor, his tongue was dry, and he had decreased skin turgor and was dehydrated. Urine examination revealed trace protein on a dipstick, and there were no active sediments on microscope.
Okay.
So your diagnosis, differential diagnosis based on that?
Sir, first I would like to comment on the syndromic diagnosis. Since the creatinine, my first syndromic diagnosis will be acute kidney injury on underlying chronic kidney disease. I would also like to keep the possibility of acute interstitial nephritis in this case. As for the acute kidney injury, as my first primary syndromic diagnosis, the acute factor, what I'm thinking it is pre-renal in this case, because he had vomiting, he had on systemic examination, he had signs of dehydration, and he also had blood loss. He had a fallen hemoglobin along with all the symptoms of anemia. So first, I would like to keep pre-renal as my acute factor. He also had a history of CABG. So even we can keep his cardiorenal as well. But on history and examination, there were nothing suggestive of any acute cardiac event. As for, I would also like to consider acute interstitial nephritis because the patient had received a checkpoint inhibitor, which is known to cause acute interstitial nephritis. Also, this patient did not have edema, did not have hypertension, only mild proteinuria with rise in creatinine. So I would also like to keep that, but a little lower down because he had been taking this drug for 1 year, and but these symptoms have developed now. So I would like to keep it as per second differential.
Yeah, I would agree on the order of the syndromic diagnosis and also on the acute factors. Yes, we no more call it pre-renal. You can always say clearly the patient was dehydrated, but the patient had history of vomiting, decreased intake, was not doing well. So probably there was dehydration, and acute tubular necrosis was the etiology for acute kidney injury. Obviously, the patient had chronic kidney disease. You yourself said that it was one and a half, I think a year or a couple of years ago. So I think this differential diagnosis, I would agree. acute interstitial nephritis would really go lower down the order, because it would be mainly AKI ATN over chronic kidney disease. Because interstitial nephritis, only thing is the patient had history of taking painkillers, so that would be one inciting, but there was no WBC at all in the urine, so that may be slightly against an acute interstitial nephritis. But again, like in the previous case, I don't know how well the urine examination was done, so that's the same argument would be there in this as well. With respect to PD1 inhibitors, I would say that checkpoint inhibitors, usually it's about 6 to 12 weeks is the time frame when which they develop acute kidney injury or acute interstitial nephritis. This has been really long, so I think you told that as well. Like that would be the last thing that you would be thinking of this patient as the cause of acute kidney injury. So I agree on the order.
So how did you go ahead after this?
Sir, when he presented to us, since he had already been transfused blood, he had a hemoglobin of 10 gram per deciliter, and he was passing black colored stool. Most likely his bleeding had stopped at that point of time. He did not have any acute any fever. His total leukocyte count was also normal. His serum creatinine was, however, high, 5.4, and we saw that the uric acid was also 14.7. So at that point of time, sir, looking at the systemic examination, we treated him as acute kidney injury, and we gave him IV fluids, and subsequently the patient showed improvement over the next 3 days. The patient is still admitted with us, so we continue to treat this patient as a case of acute kidney injury, and giving him IV fluids, and he has been responding well to the treatment.
So you are only giving good hydration.
Yes,
yes. What about the uric acid? You made a comment.
Yes. Sir, since uric acid was on the higher side, but even we could have thought about tumor lysis, but sir, other parameters were not supporting it. Like his potassium was in fact on the lower side. Phosphorus was also normal, but we just did one time 3.1, and potassium was on the.
Can you give what is the diagnostic criteria for tumor lysis?
Yes, sir. So tumor lysis syndrome is based upon the Kher-Bishop criteria. So there is a laboratory and clinical criteria. So laboratory criteria is that's after starting the chemotherapy within 3 to 7 days, if the patient has any two of the following, like if the uric acid is more than 8, potassium more than 6, calcium less than 7, and phosphorus more than 4.5 in adults, and more than 6.5 in children. So any two of these parameters within 1 week of starting the chemotherapy. And for clinical criteria, we need the laboratory criteria plus one of the following clinical presentations, like patient can have seizure or a cardiac arrhythmia. In that case, that is a clinical.
And third one?
And a rise in creatinine. Sorry,
yes. Good, very good. That's the correct answer you have given. Okay. So you are not thinking, because this is just simple uric acid elevation, and possibly with hydration, it is gradually coming down.
Yes, sir.
Okay. So that is how you are managing. You are thinking it is ATN, and most likely due to poor intake, and okay.
Also blood loss the patient had. Yes. So these are just radiological investigations that we conducted. So his ultrasound has shown kidney size of 8.5 on both kidneys, and now the patient has also developed multiple metastasis in the liver. His PET-CT, which was done in May 22, showed growth in the rectum as well as in the stomach, and when it was repeated in September, the tumor had spread. He had met in the lymph nodes, in the liver, and as well as in the lungs. And after shifting to imatinib, the severity of the disease has decreased. There is interval decrease in all the above lesions, but in none of the scans the kidney was involved. The kidney has not been infiltrated, and it has remained the same. So that is the only thing that I wanted to show. So my final diagnosis on the basis of investigations and his response and the systemic examinations is metastatic anorectal and gastric melanoma with acute and chronic kidney disease, hypothyroidism, and his post-CABG.
What is the cause of his kidney disease? CKD.
This patient, when he came to us first time, his renal function was deranged. It was 2, but on taking history, chronic kidney disease might have developed because of repeated acute kidney injury events in this patient, and not a complete recovery of the acute kidney injury events. Like he used to take NSAIDs. He had a contrast study, and he also took hemopathic drugs. So most likely he was having acute kidney injury episodes, which due to incomplete recovery might have led to chronic kidney disease. That is what.
How to do kidney biopsy in this patient?
Sir, he is having stage 4 metastatic carcinoma. So not in this case. Also, a surgical resection was also evaluated for him, but looking at all the scans and his age and the initial progression of the disease, they did not even think of resecting the tumor. So I don't think in this case doing a kidney biopsy will be.
Yes. There is no point for this patient.
Suppose if he didn't have a malignancy and he was a hale hearty person without malignancy, would you still do a kidney biopsy with an 8 centimeter kidney?
So not in active malignancy.
No, this kidney, see, the kidney size is kidney size is 8.5 centimeter. You have to see the CMD. If the CMD of the kidney is normal, even it is a 8.5 centimeter kidney, I would do a kidney biopsy. Why not?
Generally, I think
that if CMD kidney, see how the kidney looks. Even if it's a 9 centimeter kidney, if you see the ultrasound, the CMD is lost. And other features which are suggestive of CKD, I would not do a kidney biopsy in this patient. But this patient, which by ultrasound is looking okay, and we can differentiate cortex and medulla, why would not we do a kidney biopsy in that patient?
So that's the reason, what they say is if the kidney is generally smaller than 9 centimeters, other than if they are less than 10.
Size will vary depending on the build of a patient. The normal size could be from 8 centimeter to 11 centimeter. It will depend what is the width of the patient, what is the weight of the patient, height of the patient. The same size is not same for everyone. Size can be different.
I agree, Dr. Bansal, but it's reasonable to believe that it's 9 to 11 centimeters in everybody. So less than 9 centimeters usually, that's been the thumb rule. But I agree, if somebody is very short or we sometimes do take donors who have a kidney size of 8.8, 8.9. But yes, they're all their kidneys are good.
Ultrasound kidney size is a very subjective thing. Means who is looking after. So if you see the ultrasound from the 4 places, every time the size would be different. Somebody will report at 8.5, somebody will report at 9, and somebody might even report 9.2, 9.5. So it is a very objective.
But it's supposed to be the best parameter to look at the size of the kidney, compared to a CT scan or anything. Even today the ultrasound is suggested as the best modality to know the size of the kidney. Yes. But yes.
I also, though what Dr. Raja said is valid, but I agree with Dr. Shyam. The kidney biopsy length and everything is pretty subjective. As he said, you get the ultrasound done from 3 places. Some people have a radiologist from good centers, they write 8 centimeter normal kidney. They will write normal CMD, normal echogenicity size, 8 centimeter, kidney is normal. So you take it, because if you go by the kidney size of the patient, sometimes patients are short stature. I don't know. It becomes difficult to fathom whether it is normal or it is small. Professor Sakhuja, sir, on ultrasound size.
Yeah, I would agree. I agree that the general rule is that less than 9 centimeters, one would be hesitant to do a biopsy. But we have also, in patients with a kidney of 8.5 centimeters, we have done biopsies. It's not that it's an absolute contraindication. but the smaller it becomes, once if you go below 8.5, yes, then I'll be hesitant to do a biopsy, certainly.
So, but do you feel anything else needs to be done in this case, Dr. Raja?
No, sir. I think he's probably
Because
the treatment.
the patient's relatives may be saying my creatinine is still 4 milligram, 4.2 milligram. What should I do?
So
you say my kidney sizes are normal.
So we do expect that these kind of acute and chronic kidney disease generally, recover, and it's going to take some time. It's less than 2 days that this has been shown up. I just saw the investigation was 18, 19, 20, and today is just 22nd. So it's going to take some time. A week to 10 days is the time when you will start seeing some response in the form of decline in the serum creatinine.
If after a week again the creatinine remains same, let's say after you have waited for 10 days, given him good hydration, and the creatinine is still 4.5. Will our approach change?
What will you do? I wouldn't really be doing much, sir, because there is no evidence to suggest that there is any other lesions like a glomerular disease or a tubulointerstitial disease. So there is not even a single urine examination. The proteinuria is less than 500 milligrams. So I guess I would still say that it's an ATN which is probably not recovered, and try to get over the diagnosis and probably see the road ahead that way. I would not be very aggressive in this patient. This patient is not a candidate where you need to show your aggression.
So the drugs don't seem to be responsible in this patient, at least.
Yeah, it's been a year. It's been a year, I guess.
Yeah. He has been on the same medication for a year. Just for the sake of discussion, Simran, what are the common glomerular lesions in malignancy?
Sir, glomerular lesions, most common it is a membranous nephropathy, which we see about 10% patients of membranous nephropathy are shown to have cancer. Also, minimal change disease and FSGS can develop in these patients, secondary to malignancies and also secondary to some of the chemotherapeutic drugs. Minimal change disease and FSGS can develop.
Why does it develop? What will be the underlying etiology?
Yes, sir. So these
patients, as you said, people can develop membranous nephropathy is the commonest. And one can have minimal change or other lesions. What is the etiology if a person is developing membranous nephropathy?
Sir, and what do you call these entities as a group?
Yes, sir. So these are, paraneoplastic etiology, I would call it, because these tumors are releasing some antigens which form subepithelial deposits. In case of membranous, the immune complexes are formed because of these antigens which are produced by the tumor cells. So it is a paraneoplastic pathology. They get deposited in the subepithelial region in the kidneys, or they can even get deposited in the subendothelium and then progress to subepithelial and then produce food processor then produce membranous nephropathy. In case of minimal change disease, it has been shown that Hodgkin's lymphoma actually releases c-MYF factor, which produces effacement of the food process, producing minimal change disease. So these are all paraneoplastic pathologies if it is related to cancer. But if, yes, sir, this is the...
So these are paraneoplastic, there's no doubt. Besides minimal change, FSGS and membranous, can you get other glomerular lesions also?
Yes, sir. So we can get MPG and type of pattern in case of CLL. We can also get, because amyloidosis is a glomerular pathology in plasma cell dyskaryosis. So that we can get.
How do you manage that if a person comes with membranous nephropathy? You call it secondary membranous or paraneoplastic or malignancy related membranous. How do you manage that?
Sir, we will, if it is secondary to a malignancy, we have, yes, sir, if we've proven that it is secondary to a malignancy, then we will treat the malignancy. and most likely that it will definitely respond after the treatment of the malignancy.
How will you prove that it is due to the malignancy?
So, sir, in case of membranous, we have like on biopsy, we will find that in primary membranous, the IgG4 is the predominant antibody, but in secondary to some cancers, it is IgG1, IgG2. Also, or even if you don't do the biopsy, the PLA, we can do PLA2, which will be negative in case of secondary. In most of the cases, in primary it is positive, but not all. It is not confirmatory. Confirmatory, sir, on biopsy.
Yeah,
Also,
so you can't be 100% sure of glomerular lesion being paraneoplastic. You can never be 100% sure. There can always be a coincidental pathology. That possibility always remains, So this is a diagnosis that is difficult to confirm with certainty. You can suspect it, difficult to confirm. Those points which you mentioned about IgG4 and PLA2R are valid, but not always, not 100%.
And many patients get treated because many times malignancy gets diagnosed pretty late. You find malignancy diagnosis comes after 6 months, 1 year, and patients get treated as usual. Yeah. Dr. Raja and Dr. Shyam, your comments.
Yeah. So you can at the best say there is an association, and the causality is very difficult unless you're able to show that your rheumatoid tumor and the proteinuria gets abated in next 6 weeks. So that's the easiest way. But again, even that also you cannot say the causality. You can just say it's an association with the malignancies. So most of the times it's not a renal cell carcinoma, but it's usually, or melanoma, it's usually the adenoCA of the gut that is commonly associated with malignancy. Breast carcinoma, adenoCA of the small or the large intestine. So that's the one which is commonly associated. As you rightly pointed out, they are generally PLA2R with you, and they're more tend to be NEL positive, NEL1 positive. That's another one. That's easier way of picking up, because IgG 1 to 4 is not done in everybody, but now NEL staining is freely available and they are doing. So that's an easy way to pick up. So if you get a NEL positive, you see for malignancy, you see for any history of complementary drug use. So that's how you go about this. So yes, and you don't, essentially when you have a malignancy, the priority is not to treat membranous, because membranous is not going to eat away the kidney in some time like MPGN or an RPGN. So you can wait, you can put the patient on anticoagulation and wait. So all you need to do is AC or ARBs and anticoagulation, statins, and wait, treat the malignancy. So that's how you go about and see and hope for the best.
Mr. Shyam, your comments.
No, so I think she has given good answers. So only thing so she has forgot to see other glomerular lesions, Dr. Sakhuja asked. So you have forgot thrombotic microangiopathy and the vasculitis. These are some of the other lesions which could be found because of the drugs. So these are important, but more than the MPGN or this. Membranous is a different class, and that is because of the malignancy, not drug-induced. So rarely, drug-induced is these lesions, FSGS, MCD, and all that. So should be, I think.
Yeah.
I think Professor Sakhuja, sir, I think both the cases have been AKI cases, which is a common manifestation of malignancy. And the management in both cases, one has been conservative, and in second, the evidence was some suggestive, so steroids were given. The recovery in the first case was prompt. In second case, recovery is ongoing, and I presume in due course the recovery should occur. And I also feel both the students did very good job. They are prepared the topic and they were aware of what is happening and how they are managing the case. I leave it to Professor Sakhuja to say a few words And I also must say that this is the 24th and last episode of Master's class. And my gratitude is to Professor Sakhuja, my teacher, Professor Kher, who were always there and who were just actually the doyens who were always there in the meeting. And more importantly, all the examiners and students. It is purely because of the examiners' interest and passion for teaching that they came forward and they taught that the program became a successful program. And also to Microlab to always support, because all the administrative support was theirs. So I thank them also profusely. And though we will come back with the other program now shortly, but this may be finishing. For the final comments and conclusions, I hand over to my teacher, Professor Sakhuja, please.
Thank you, General Varma. Just a few additional comments. See, onconephrology, which is what we were discussing today, is a very vast area. And we have covered only a small part of it today. We've mainly been talking about immune checkpoint inhibitors and the toxicity associated with them. And we've talked about paraneoplastic glomerular disease. These are the two areas we've covered. But one should remember that there are a lot of other problems that can be encountered in these patients. One of them is electrolyte abnormalities. And of those, hypercalcemia is the commonest, which is mainly seen with multiple myeloma and with lymphomas. Other anti-malignant drugs causing nephrotoxicity are also very common. And in them, I'd like to point out the platinum compounds in particular. We have at least 3 platinum compounds: cisplatinum, which is more nephrotoxic, and the less nephrotoxic ones, which are carboplatin and oxaliplatin. All of these can result in AKI, which may be reversible or even sometimes irreversible if too large a dose has been given and hydration has not been looked after. And then there is a large number of drugs which can cause TMAs, which include gemcitabine, mitomycin C, anti-VEGF drugs, tyrosine kinase inhibitors, and immune checkpoint inhibitors. Then you can have FSGS occurring as a result of pamidronate or sometimes zoledronate. You can have crystal-related nephrotoxicity due to methotrexate. So these are some other drug nephrotoxicities that are commonly encountered in patients with cancer. So there is a wide variety of problems that such patients can pose to the nephrologist. With that, I'll hand it over back to Mr. Raja and Microlabs to wind up the session.
Are they around, Mr. Raja? Mr. Deepak?
Yes, sir. Yes, sir.
Yeah. Yeah, over to Mr. Deepak. I think if his mic is not functional.
Yes, sir.
Yeah, please go ahead. You can conclude the session with thanks.
Maybe General Varma, you can conclude.
I think he's muted. I once again thank both the examiners and students and Professor Sakhuja. Dr. Kher was joining, but there was an emergency at the last moment. So while he was switching on, there was emergency. He had to rush to the hospital. So we are missing him. But thank you very much, Professor Sakhuja. And thank you very much, examiners, and all the faculty which have been involved in masterclass. Thank you so much, and bye-bye.
Thank you. Thank you very much.
Thank you, Doctor.
Thank you very much, sir. Thank you for coming, sir.
We'll soon come with next our upcoming regain program, and we'll announce to all our students. And once again, thanks for each and everyone's support. Goodbye. Night.
Bye. Bye-bye.